Good afternoon. Thank you for joining us for the Ask a Radiologist webinar series. Before we get started, I'm going to share some housekeeping items for today's webinar. Everyone on the call will remain muted for the duration of the webinar. At the end of the webinar, we will open the floor for live Q&A. We encourage you to ask questions, and you can submit your questions at any time using the chat box feature in the Zoom platform. If you would like to ask your questions live, simply click on the Raise Your Hand button and we will unmute you during the Q&A portion. Today's webinar will be on the correlation of breast density and breast cancer screenings, and we are joined by Dr. Amy Chudgar and Travis Roseborough. Dr. Amy Chudgar is a radiologist with Charlotte Radiology and is subspecialized and board certified in breast imaging and nuclear medicine. After completing her residency at the Hospital of the University of Pennsylvania, she completed a fellowship in breast imaging at the Memorial Sloan Kettering. Travis Roseborough is a physician liaison at Charlotte Radiology who builds relationships between our radiologists and providers. With over 20 years of experience in pharmaceutical sales, Travis can manage and solve your imaging needs. I'm going to go ahead and pass it over to Dr. Chudgar to share her presentation. Thank you.
Hi, everyone. Thank you for joining today. So I'm going to be talking about breast density and breast cancer screening. So the goals and objectives of today's presentation is to talk about breast density and why it's important. I'll talk about conventional 2D mammography versus digital breast tomosynthesis, which you may also be familiar with as 3D mammography. We'll talk about what some of the advantages are of DBT. And then I'll talk a little bit about some of the supplemental screening options there are available for women who have dense breast tissue as well as elevated risk factors for breast cancer. Specifically, I will talk about screening breast ultrasound as well as breast MRI. And then I'll briefly mention some further directions about supplemental screening. So just a quick breast cancer overview. 1 in 8 women will be diagnosed with breast cancer over their lifetime. 1 in 39 women will die from breast cancer. After skin cancer, breast cancer is the most common cancer in women, and it is the second leading cause of death. 1 in 6 breast cancers do occur in women in their 40s, and these tend to be more aggressive than those in older women, and the incidence of breast cancer does increase with age. These are just some statistics from the American Cancer Society from 2019. So you can see that the number of invasive breast cancer diagnoses in 2019 was close to 270,000, and the number of deaths was 42,000. So screening mammography has been shown across numerous studies to have it show decrease in mortality anywhere from 20 to 40%. The cancer detection rate with screening mammography is 5 cancers detected out of 1,000 patients screened. With screening mammography, the whole goal is to detect cancers while they're very small before they're able to be felt. So they often require less extensive treatment and they have improved prognosis. And this is a cheap, quick exam. So this is kind of a case where 2D screening mammography works very well. So this is somebody with fatty breast tissue, and she has a couple of nodules in the upper outer quadrant, which are very visible despite the fact that they are quite small. So she was a 44-year-old who underwent a screening mammogram. So she came back for an ultrasound and had these abnormal masses in her right breast 11 o'clock location. She had a biopsy, and this turned out to be a triple negative invasive ductal carcinoma and ductal carcinoma in situ. So this is basically a case where we see screening mammography detecting a very aggressive cancer while it's still small. But the main limitation of screening mammography is that it is limited in women who have dense breast tissue. So if you've ever looked at your patient's mammogram reports, you may have seen this little notification under the recommendation that because of your patient's breast pattern and or tissue density, we recommend that she consider adding tomosynthesis. This technology has been shown to improve accuracy. And you'll see this in patients who have a breast density of C, the breasts are heterogeneously dense, which may obscure small masses, or breast density of D, the breasts are extremely dense, which lowers the sensitivity of mammography. Well, just to talk a little bit about how breast density notification became kind of part of the report. So this really started with a woman named Nancy Capello. So in 2004, she had a normal mammogram, and about 6 weeks later, she had a physical exam, and her physician felt a palpable ridge. So she was sent back for additional imaging. She had a repeat mammogram, which again was negative, but she had an ultrasound showing what proved to be a breast cancer, which was metastatic to a lymph node. She had dense breast tissue, but was not aware that this limited her mammographic evaluation, or that supplemental screening could have helped to overcome this limitation. So she started a grassroots effort and advocacy to make sure that women were informed of their breast density and of the limitations of mammography. So she started the Are You Dense Incorporated. And in 2009, Connecticut was the first state to require a density notification in all of their reports. And by 2019, this is now mandatory in all 50 states. So now let's talk a little bit about the different types of breast density. So breast density refers to the amount of fibroglandular tissue that you see on a woman's mammogram. And this is not how a patient's breast feels on a clinical exam. It's really just dependent on the fibroglandular tissue identified on the mammogram. So on the mammogram, the fibroglandular tissue appears white and fat appears black. And then, so we have the different BI-RADS categories. BI-RADS stands for Breast Imaging Reporting and Data System. This is basically the nomenclature that we use for all of our mammography reports. So we have 4 categories. So we have A, fatty, B, scattered, C, heterogeneously dense, and D, extremely dense. And 10% of women have fatty tissue, and then 10% have extremely dense. So most women will fall into the 2 middle categories, scattered or heterogeneously dense. And women who have heterogeneously dense or extremely dense are considered in the dense category. But determining breast density can be somewhat complex. It is most often determined subjectively by the interpreting radiologist. At Charlotte Radiology, we also do use software. It's called Volpara, which determines the mammographic density volumetrically. So this does give us a more objective, quantitative interpretation, but this is not always perfect or reliable. So it's ultimately decided by the interpreting radiologist. So you may see sometimes that a woman's density will switch from B to C because they fall somewhere in the middle, and it just depends on who reads their mammogram that year to decide. The reason that breast density is so important is because of its masking effect. So when we're reading a mammogram, we're really trying to find a breast cancer which will also appear white. So the more white fibroglandular tissue there is, the harder it is to find. So basically, you have a higher likelihood of calling something negative when there could be a cancer present, or increasing your false negatives. This also increases us detecting patients presenting with interval cancers, meaning that they have a negative screening mammogram return within the year, and they're able to now feel a breast cancer. So these tend to have a worse prognosis. Another important factor is that breast density itself is an independent risk factor for breast cancer. So somebody who has extremely dense breast tissue has a 4 to 5 times relative risk of developing breast cancer compared to somebody who has fatty breast tissue. They have a 2.1 times relative risk compared to somebody with just average breast tissue, and somebody who has heterogeneously dense has a 1.2 times relative risk. And as an individual, having dense breast tissue is not as important of a relative risk factor as many other things, say a genetic mutation like BRCA, or having a history of atypia. But on a population level, because breast density is so common, it is important that we pay attention to it. So let's now talk about mammography. So digital mammography is considered the gold standard for breast imaging. So when we take a look at how 2D mammography works, basically the breast is compressed between the compression plate and the imaging detector, and then the X-ray tube takes a single perpendicular 2D exposure like this. And then you get your image. And then this is, say, a breast cancer in that red window. When we compare this to tomosynthesis or 3D mammography, the X-ray tubes moves in a 15-degree arc across the breast, and multiple low-dose images are acquired from different angles. So this creates a projection image. A computer algorithm will reconstruct these projection images into 1 millimeter thick slices, And so we're able to scroll through these images like a CT. And at Charlotte Radiology, we basically use those series of low dose images to reconstruct a 2D image as well. So this allows us to keep our radiation dose approximately equal to that of a single 2D mammogram. So this is just kind of showing how that works. And this is another graphic showing the series of images being taken, and you can see that you get these separate little slices together, which you're now able to scroll through. And this is your cancer again, but now you're able to actually scroll through the images and you can stop at the exact slice where this is located. So the 3D imaging or digital breast tomosynthesis has been shown to have some very important advantages compared to just 2D imaging. So it has been shown to improve cancer detection rate, and particularly invasive cancer, so the ones that are clinically important. So it's been shown to have an increased cancer detection rate of 1.2 to 4.6 per 1,000 screens. The other important thing that 3D offers is that it reduces the number of false positive recalls. So the number of times that patients are called back for a possible abnormality, when they come back and everything turns out to be normal. Well, 3D helps to reduce that. And this has been shown, to reduce this by 15%, improving the specificity of the test. And as I mentioned, the synthetic reconstructed 2D mammograms has allowed us to keep the radiation dose to be comparable to a conventional 2D mammogram. So this is an example of a 51-year-old who was presented for screening mammogram. Her 2D images really show no abnormality, but on her tomosynthesis images, we can see a spiculated mass in the upper outer quadrant. And this is a close-up image kind of showing that spiculation. So an ultrasound shows a corresponding 1 cm spiculated nodule, and this was an ER/PR positive HER2 negative invasive ductal carcinoma. So while we have seen that the 3D imaging increases our cancer detection rate and decreases recalls for both dense and non-dense breasts, we have found that the greatest gain of this is really for women and with heterogeneously dense breast tissue. So the women who fall into that C category. Unfortunately, there are still limitations in women who have extremely dense breasts, which was that 10% of women. So here's a couple of studies where they found either little to no improvement in cancer detection rate, as well as really some reduction or no reduction in recalls. So knowing that 3D mammography does have some limitations, particularly in dense breast tissue, now I'm going to talk a little bit about some of the supplemental screening options. So, and this is really for women who have dense breast as well as additional risk factors. So we'll start with screening breast ultrasound. So this is where a method of screening where a methodical detailed ultrasound is performed at each breast, either by a technologist or by a physician. This has been shown across multiple studies to show an increased cancer detection rate of 1.8 to 4.6 cancers per 1,000 women screened. And they've been found that these detected cancers are being found early while they're still node negative. It is ultrasound in general is widely available. It's relatively inexpensive. It does not have any radiation. It doesn't require any IV contrast. And it is not limited by breast density. However, there are some limitations. So the main one is that it significantly increases the false positive findings. And it has a lower positive predictive value for biopsy compared to mammography or MRI. So the PPV3 or your positive biopsy rate is about 8 to 20%, depending on the experience of the operator. The other big disadvantage it has is a high short-term follow-up rates, where basically we will see something under ultrasound that looks probably benign and patients have to return in 6 months for a follow-up. Ultrasound is operator dependent. So it's best performed by physicians or well-trained technologists. So this really limits on who is able to perform this type of study. It is time and labor intensive. And 3D mammography detects approximately half of the additional cancers detected by whole breast ultrasound. and has fewer false positives. So who qualifies for screening breast ultrasound at Charlotte Radiology? So the patient must have a negative mammogram in the past 6 months. So just remember that a screening breast ultrasound does not replace a mammography. This is a supplemental adjunct screening. And the patient needs to have dense breasts, so heterogeneously dense or extremely dense on mammogram, and they need to have one additional risk factor. So something like family history of breast or ovarian cancer, a personal history of breast cancer, or a prior biopsy showing atypia or a high-risk lesion. Also, patients who qualify for breast MRI, but they're unable to have an MRI for various different reasons, such as expense or claustrophobia, contrast contraindication. So if those patients can't get a breast MRI, then they could certainly get a screening breast ultrasound. So this is an example of a 43-year-old. So this is not a screening patient. This is somebody who came in as a diagnostic patient with a self-palpated lump in her right breast. So there's a BB at the area of concern, and there's really no underlying mammographic abnormality, but you can see she has extremely dense breast tissue. So this really limits the evaluation. But on ultrasound, you can see that there is an underlying 1.5 centimeter irregular mass. So she underwent an ultrasound core biopsy, and this yielded an ER/PR positive HER2 negative invasive ductal carcinoma. She had an MRI, and this also very clearly shows the 1.5 cm biopsy proven malignancy. So now we'll talk about the last screening modality, which is breast MRI. So contrast enhanced breast MRI is the most sensitive modality for breast cancer detection. It has a higher cancer detection rate than all the other modalities, with an additional 15 to 20 cancers detected per 1,000 women screened. It is more sensitive than 2D or 3D mammography or ultrasound in high-risk populations, even when those two are performed together. It is not limited by breast density, and it has no radiation. Some of the limitations with contrast enhanced breast MRI is the recall and biopsy rates are higher than just regular mammography, although your positive biopsy rate of MRI is similar to mammography. It is a very expensive test. It doesn't always have great insurance coverage, can be quite inconsistent, and there is limited access to MRI. It does require IV gadolinium, and this can lead to nephrogenic systemic fibrosis in patients with renal failure. And we know that it can cause deposition in certain parts of the body, including the brain. We don't quite really know we haven't seen any problems with that, but we really don't know what the long-term effects of that are. So who qualifies for MRI? So this is really for screening. This is really done for women who are high risk. So women who have a known genetic mutation, such as a BRCA mutation, which has been tested themselves or in an untested first-degree relative. If they've had chest radiation between the ages of 10 and 30, or if they have a known greater than 20% lifetime risk of breast cancer. And these are some of the high-risk populations. So these are some of the genetic hereditary mutations, again, the chest or mantle radiation. And these are some of the risk factors that may put them at a greater than 20% risk. So this is an example of a 46-year-old woman who had a history of a left excisional biopsy for flat epithelial atypia. So she had a negative mammogram, and 6 months later, she had a breast MRI, which basically showed this 5 millimeter enhancing nodule in her right breast. This is a unique focus compared to the rest of the breast tissue. So this did undergo an MRI biopsy, which ended up yielding an ER/PR positive HER2 negative invasive lobular carcinoma. And just to mention a couple of words about what we can look forward to in the future. So abbreviated breast MRI is a shortened protocol where we have fewer sequences. So it is a much faster study and it is cheaper. And this is something that we are planning to implement hopefully by the end of the year. So the benefits of using abbreviated breast MRI is that it has studies have shown that it has a confirmed equivalent accuracy compared to a full protocol. It is faster, so it takes about half the time as a full MRI. And because it's faster, and because has less images, it is more cost effective compared to the full MRI, and it requires a shorter interpretation time. Limitations, again, false positive results, and then some of the cancers can remain difficult to diagnose on MRI, specifically DCIS. And this is one study that was just recently published in JAMA last year. So they were looking at abbreviated MRI in women who were average risk but had dense breast tissue. So they found that abbreviated MRI had a significant higher rate of invasive breast cancer detection compared to 3D imaging, with a cancer detection rate of almost 12 per 1,000 versus 3D had about 5 per 1,000, so almost over twice as much. Once we do begin abbreviated MRI, we will, here at Charlotte Radiology, we will specify what patients will qualify for this. I don't know that we're going to be at a point where we will be allowing average risk women with dense breast tissue, but this may be something where we go towards in the future. So the takeaway points from today's lecture is that screening mammography reduces mortality by 20 to 40%. The greatest benefit is starting at the age of 40 with annual screening. About 50% of women have dense tissue. 3D mammography detects more cancers, particularly invasive cancers, and helps to reduce recalls compared to 2D mammography. But it is limited in women with extremely dense breast tissue. Women who do have dense tissue and have additional risk factors may benefit from supplemental screening. So those being screening breast ultrasound or breast MRI for women who have a greater than 20% lifetime risk of developing breast cancer. And abbreviated MRI in the future will offer a faster and cheaper option for supplemental screening. So there's some references, and I'm just giving a special thanks to Jenny Rowland and Shannon Hill for sharing some slides. And this is my contact information if anyone has questions that they think of later and want to email. So I think now I can answer any questions.
Yes, thank you so much, Dr. Chudgar, for sharing this incredibly informative presentation. So we're going to use the last roughly 10 minutes of the last part of the hour here to answer any Q&A questions. So again, you can answer questions in the Q&A feature in the Zoom platform, or if you would like to ask your questions live, please click on the raise hand feature in Zoom, and I will go ahead and unmute you so that way you can speak to Dr. Chudgar.
Dr. Chudgar, while we wait for questions, that was an amazing presentation. I thank you. I think it gives a lot of clarity to some of the areas where providers may have questions about what to order, when to order. With that being said, when you have people referred in, are there any things that you would like the providers to know prior to or after they refer a patient?
Before they refer patients for their mammography?
Yes.
I think it's helpful to know any family history, if they have a history of breast cancer or family history of breast cancer or ovarian cancer. It's particularly if they're coming from an outside institution, it's helpful to know if they've had prior biopsies or history of any kind of surgery for breast cancer, anything like that. Those are helpful for us when we're reading the mammograms. Usually patients will know this information and kind of supply that, but it's helpful to have that information. Mm-hmm. I think other things that are helpful, just kind of in general, is if for patients who come in with, say, a clinically palpated lump in their breast, I see a lot of physicians do this, and I think it's extremely helpful if on the order form, if you specifically state where you feel where the abnormality was detected, because that way we can definitely ultrasound the area. Patients often forget, and we don't always have access to everybody's clinical notes. So I think that can be extremely helpful.
Yeah, those are some great points, because at Charlotte Radiology, we want to make sure that we give the patient the best overall treatment with that information. It can set up the appointment to go further, and we can follow back up with that provider. So thank you for that information. Mm-hmm.
Okay, I don't see any questions coming through right now, so we'll just give it another minute. If nothing else comes through, Dr. Chudgar, we could go ahead and wrap it up just a few minutes early.
Yes.
I think I see a question.
All right, so we have a question. Oh, can you see that one, Dr. Chudgar? Here, I'll read it out loud. So it says most recent NCCN guidelines upgraded the BARD1 mutation to increase lifetime risk of developing breast cancer. To consider breast MRI with this, should you consider breast MRI with this patient population as well?
Yeah, I should have included that one on the list as well. Yeah, so I mean, that's definitely another mutation that we would, that sounds like they also meet the greater than 20% lifetime risk where they would qualify for breast MRI.
Okay, thank you. All right, if we don't have any other questions on the line, we'll go ahead and end this webinar just a few minutes early. But again, Dr. Chudgar does have her email address listed right here on the PowerPoint slide. So please feel free to reach out to her if anything else comes to mind as you serve your patients.
All right, thank you.
Yes, thank you so much. Thank you, Dr. Chudgar, for taking the time to do this presentation for us today.
Thank you for everyone participating.
Okay, have a good afternoon.